Hello, everyone. Thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinoza, the Program Coordinator at CSCLA, and I'm honored to welcome you to this week's webinar titled Comfort and Care of Patients and Families Through Palliative and Hospice Care. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is the premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. Please enter questions for the speaker into the Q&A feature found at the bottom of the Zoom window. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but we'll get to as many as possible. Please use the chat feature to share comments and resources with other participants or to ask questions of CSCLA. We ask you to limit chat comments to information relevant to this topic. Laura Kanofsky is a licensed clinical social worker and board-certified music therapist. She has worked in hospice care for 18 years and is currently working with Dynamic Hospice as a social worker, music therapist, and co-facilitator of their bereavement support group. Her professional experience spans many clinical settings and populations, including inpatient and outpatient psychiatry, community mental health, schools, and an ongoing private practice of 25 years. It gives me great pleasure to welcome today's speaker, Laura Kanofsky.
Thank you very much, Abby. Honored to be here, and I will endeavor to explain about both palliative care a little more briefly and hospice care a little more in depth, and of course to answer any questions that arise. So I'm going to start with talking about palliative care, which and much of this may be familiar, but I'm going to go through the basics to be sure we have a grasp of the two and some of the similarities and differences. So palliative care is medical care for those who have a serious illness, and the goals are really about managing pain, managing symptoms, other types of symptoms, and also managing the side effects of the treatment of cancer or of the illness that the patient is living with and being treated for. So someone who, for example, has cancer or heart disease or COPD or Parkinson's disease, and whose illness is not terminal or not yet terminal, or possibly is considered terminal, but for whatever reason, the person has opted not to go with hospice care, they might choose palliative care in order to get treatment for a wide range of symptoms, including pain, fatigue, nausea, anxiety, depression, shortness of breath, difficulty sleeping. Palliative care also supports patients in dealing with the emotional toll of the illness and diagnosis, and it can help to clarify what treatments are available, so that easing, thereby easing decision making and kind of planning for the future. So, and I'll talk about, I think I'll just wait until I talk about hospice to define terminal illness. But so both palliative care and hospice care aim to optimize the quality of life. That is something that is fundamental and common to both. The difference it's that on palliative care, you could also be undergoing treatment for the illness, what would often be considered aggressive treatment, chemotherapy, immunotherapy, that would not be considered compatible with hospice, and importantly, would not be paid for by Medicare. So it's sort of an either or. So that's considered concurrent care, and that is something that is available with palliative care, not with hospice. So all treatments under palliative care are they're still covered by Medicare and insurance under the person's primary coverage. And palliative care lasts as long as it needs to, until the symptoms are stabilized without the care. So it's really about symptom management, and the frequency of visits tends to decline as the symptoms are better controlled. Typically, nurses visit, I believe, only maybe every other week, and sometimes only once a month. So it's not a high frequency, but there might be other disciplines involved, and certainly spiritual support, social work are available if they're desired under palliative care. So I hope this helps and doesn't complicate, but palliative care is covered under Part B of Medicare if someone is on Medicare, and that means that it's like a doctor. So you can go into the hospital for a certain procedure or treatment, and you continue to work with your doctor. In fact, ideally, the palliative team would be consulting with your primary doctor about care. And patients who have multiple needs, skilled needs like for wound care or catheters, can also have home health. So you can be under home health service, if that's something familiar, and palliative care at the same time. Whereas under hospice care, it's an either or. You either have hospice or you have home health. And palliative care nurses don't make visits around the clock. And that is a major feature of hospice care. So they have their scheduled visits, but they are not available 24/7. And what else? Palliative, again, part of optimizing the quality of life is being in touch and being supportive of the family or the caring circle, and that is true of both palliative care and hospice. That is pretty much so palliative care can go on for quite a while, but once symptoms are stabilized, people do get discharged off of palliative care. So hospice, on the other hand, I've heard it said that, and this makes utter sense, that all of hospice is palliative, but all of palliative care is not hospice. So hospice seeks to provide comfort. It is comfort-focused care. It is for people qualify for hospice when they have an illness that a doctor will certify as being terminal, and terminal means that should it run its normal course, a person could die within 6 months. That doesn't mean that they will die within 6 months. It means just that is conceivable. People are often under hospice care for a couple of years. And so long as there is some objective element of decline, there does have to be some decline, then they can continue to stay under hospice care. So you qualify when a primary doctor or an oncologist or another specialist makes a prognosis that should the illness run its regular course, the person could die within 6 months. And starting on hospice requires a physician's order. So if someone is experiencing, has been ill and is really starting to decline, is much weaker, has lost weight. I mean, there are many circumstances that cause somebody to say, hey, wait a minute, can't get up, can't go to an appointment anymore. Often a doctor will recommend hospice, or the patient or family might be curious about hospice, and one can always be evaluated for appropriateness. I have found anecdotally that a lot of people that come onto hospice would have qualified much sooner than they thought. And really, one reaps the benefits of hospice when one does come on sooner, because rather than have it feel like an urgent need and then it only lasts for a couple of weeks, there's a lot of support that is available through the hospice team, which I'll talk about right now. So hospice serves as the go-to, or the primary medical care for the patient. Once you elect hospice, hospice really drives the care. So there's always at least one medical director of a hospice. The mainstay of hospices are the nurses, both RNs and LVNs. There's always going to be an RN assigned to the case. And a hospice can provide care wherever the patient lives. So if that's at home or in someone else's home, or in a board and care home, or in an assisted living facility, the hospice team will go wherever you are. One of the crucial roles is alleviating physical pain, emotional pain, spiritual suffering, and providing also additional comfort by focusing on the mind, body, and spirit of family members or whoever is in the caring circle. So, it's not unusual for that to become a focus of care, especially with the non-nursing members of the hospice team who are, providing support to those who are really grappling with anticipatory grief. So we have, a whole team, and I'll get into that as well. And, part of being on hospice is that needs they're continually evaluated because they change. I mean, this is a dynamic process. And so the needs of both the patient and the family, in order to address them and the possibly changing goals of care. So generally, at least weekly nursing visits are provided, and it's more frequent when needed. So if there's something that has just arisen, or there's some change or some new symptom, Often the visits will be bumped up to 2 or maybe 3 times a week. And when a patient is approaching the end of their life and imminently dying, um, they get, visits from the nurse daily at least. So in addition to the nurse visits, there are certified nursing assistants or aides who are available to help with bathing a couple of times a week if that's wanted. Sometimes even when there is a family member or a caregiver who can help, just having the extra eyes and set of hands can really be helpful when someone is really weak. So hospice also provides management and usually same day delivery of medical equipment, medication, and supplies. So, example of medical equipment would be electric hospital beds and bedside tables, oxygen, wheelchairs, uh, shower chairs, all kinds of stuff like that. And examples of medication would be any routine medication refills and anything for symptom control. So that winds up being a pretty broad area. So if nausea is involved or agitation is, anyway, it covers most medications, and is, as I said, usually very responsive about delivery. And supplies would include, um, depends, bed pads, ointments, gloves, wet wipes, food thickener if needed. And I think that one of the most crucial, significant, and one of the most comforting features of hospice is the 24/7 nursing care available. So I think once people realize that even if it's just something they're uncertain about, it doesn't have to be an absolute crisis, but whichever end of the spectrum it is, they can call. Usually it's the main number to the hospice. There is on-call availability to connect with a nurse at any hour of the day. And that nurse might be able to help on the phone or guide you to a medication. Under hospice care, people are delivered what's called a comfort kit. It's kind of like a just in case package of medications that may or may not be needed, but if they are, they're right there. And same with oxygen. Oxygen is provided, and if it's tucked away in a closet, that's fine. But then if it's ever needed, there's not a need to wait and be in distress. So, but if they're not able to help over the phone, then they send someone to make a visit. It's that simple. So you'll have someone come out at 3 a.m, whether it's a breathing issue, an agitation, a fall that happened. So hospice really, in that sense, replaces 911 and becomes also your emergency contact. So in addition, as I mentioned, a big part of what the hospice team does is support and communicate with patients and their families and caregivers. Some people have had caregivers for a long time. Certainly patients, for instance, who've had dementia for a long time often have had caregivers in the family for many years, and they become very, very attached, and their grief is as real as anybody else's, and they need support. So, and also we communicate with the primary physician. So a lot of times when people go onto hospice, they want to know if they can keep their primary doctor. And my experience is that in the vast majority of cases, even when your primary doctor or your oncologist or specialist has a close relationship with you, they often don't want to be, they want to defer to the hospice physician, and they may also not want to be called at 2 or 3 in the morning. But they often say that they want to be updated. They want to be kept in the loop. And we, of course, will do that. The nursing director or the case manager or the director of nursing or whoever will stay in contact when there are any significant changes or any updates. So, and another thing we provide, not insignificant, is bereavement support. So it was mentioned that that I do a bereavement group. That group has been going on for many years, and it is done under the auspices of our hospice. Every hospice is required to have a bereavement program, and it varies from hospice to hospice. Ours happens to provide some individual bereavement support for those in the family or caring circle or whoever has experienced a loss, as well as a support group, as well as mailings. It varies from hospice to hospice. There isn't a clear regulation about that, or requirement, just that something be provided. But we happen to view that as a really important piece of the care. I could also talk about medical aid in dying. I don't know if that's something that that you guys have already had a presentation on, so maybe I'll just wait until Q&A. But we work very closely in tandem with prescribing doctors who do provide medical aid in dying, and we don't provide it directly, but we are very supportive of our patients and families, and who do pursue that avenue. So, but maybe I'll wait on that and see what the preference is. So I am going to just review a couple of the myths and facts about hospice. So one of the myths is that that the signing on to hospice means discontinuing all medication, that you stop medication and you only go on what the hospice decides to provide. Excuse me, that is not at all the case. At the time of admission, medications are always reviewed closely with the admitting nurse, and then in consultation with our medical director. There may well be some things that are seen as extraneous, as unnecessary, or possibly even causing unneeded side effects, but anyone always has the right to stay on any medication that they're on. Sometimes it does simplify matters to let go of some of them, but no one will ever be made to stop taking any medications. Of course, as I said, chemo type meds are not compatible with hospice. So there's a question then of, one wants to utilize hospice care when one is really buying into the philosophy of hospice care, and that is focusing on comfort, not on curative treatment. And it's very understandable to have some ambivalence about that when starting, but that is that becomes a sticking point in a few areas, and I'll I'll touch on a couple of them. So, so anyway, but main point being that one can continue on one's medications, one's supplements, whatever you're taking. Another myth, and I touched on this earlier, is that hospice is just for the last few days of life. And, you know, I'll just say that sometimes doctors themselves have a hard time having a frank conversation with their patients and not seeking to offer more or different treatments, and they sometimes wait to say this might be the time to move to hospice. The truth is, again, this is anecdotal, but I have seen cases where we've had like quite seasoned nurses say, "Wow, this person is, you know, so frail, so fatigued. You know, they're just coming onto hospice care. I don't know that they'll have a really long time with us." And then lo and behold, they have this break from some of the aggressive treatment, and which is completely sensible that they had that aggressive treatment, but that their body gets a little bit of a break and they sort of have a period of stabilizing for a little while and really being able to be more relatively free of symptoms or have very diminished symptoms. So sometimes that can actually happen, that you have more time than you think you will, and that time is able to be used for the things that we hope and intend hospice to be for, and that's you know, getting the most quality out of what life remains and having proper closure with family, sometimes repairing relationships even, and you know, getting to feel that it's a good ending. So another myth is that hospice does not provide antibiotics or any other kinds of treatment. There are lots of treatments that are provided, and the truth is, antibiotic is something, whether it's for a urinary tract infection or some other kind of infection, something that's completely up to the patient and family. Hospice does not do extensive lab work, however. So that's just something to know. Another myth is that you can't see your primary doctor. So it is true that if coming on to hospice for cancer, as I said, hospice becomes kind of the primary medical care. So Medicare will not pay for you to both have hospice and to see your oncologist, because if the diagnosis for hospice is cancer, then you can't see both, have both hospice and your oncologist, but you can see your primary doctor, you can see other doctors, dermatologists, they would all be covered under Medicare. Or I know I'm mentioning Medicare a lot. If Medicare is not material, if someone is younger than Medicare or hasn't received disability for a couple of years to qualify for Medicare, you know, the other way to qualify for Medicare, then this would apply to insurance as well. So those are some of the myths. There may be, I'm sure there are others. I just can't think of what they might be right now. Here are some facts. One is that you cannot be receiving chemotherapy while on hospice. You can graduate from hospice and be discharged onto another service. So I mentioned earlier that that to continue to qualify for hospice, there are these recertification periods, first every few months and then every couple of months. And um, and if someone is showing some bit of decline, there seems to be a trend, even if there wasn't something super obvious in the last 2-month period, let's say, if there seems to be a trend of not being very stable and not improving, one will continue to qualify. But if for an extended period, there seems to be a really strong stabilization, no weight loss, no increased needs for meds, no pressure sore, no increased agitation, no, then the team will start to think about whether it's appropriate to stay under hospice care, even with a terminal diagnosis. And that is because CMS, Medicare will not, when they go to review cases and they, or the other accrediting bodies for Medicare would say, how come, what was this person actually being treated for? So we would then have to consider a discharge. When we do that, we do it really thoughtfully. It doesn't happen in the majority of cases, but it does happen from time to time. So someone might be discharged onto home health, and then maybe to a mobile doctor or home health and palliative care. We would, consult with you, confer with you, with the team, with the medical director, and decide whatever is the most appropriate next step. And there'd be plenty of notice as well to get a plan lined up. And also that a patient can revoke off of, revoke services and go off of hospice. So maybe that's another myth, that once you're on hospice, you can't leave. That is not at all the case. And, sometimes this is not encouraged, but sometimes people actually go off of hospice, they revoke hospice in order to go into the hospital to do a procedure that they need to have done that can't be done at home, and then come back and readmit onto hospice. If that were to happen like really repeatedly, that wouldn't be a good thing. But that does happen from time to time. Or sometimes someone suddenly says, I really want to know my numbers. I really want to know where I am. I really want to have a scan. And they might change their mind and say, I want to do aggressive treatment, and that is okay to do. Usually when people go into hospice, that is a long-term decision they've made, but it doesn't have to be. And another fact is that hospice does take, as I think I mentioned this earlier, takes the place of 911. So we do send nurses out for emergencies. If someone has fallen badly, or if God forbid, a bone is sticking out of you, or you're bleeding profusely, then of course, call 911 and hopefully call us too to let us know. But in a circumstance like that, even if you called us, we the hospice nurse would call 911. But for those other situations that I described, where just having increased, not just, but having increased symptoms, things of that nature, you would call the on-call number, the main number. I just want to go back and mention, and one more fact before I go back, is that physical therapy and occupational therapy are generally not covered by hospice. And that again has to do with the thrust of hospice care being comfort focused, not rehabilitative. Some people, I have certainly had patients who are not comfortable with that, that feel that they want to be as, prevent deconditioning as much as they can, even though they are on board with the hospice philosophy. And in those instances, it's well worth it for them. They find to have all the benefits of hospice and also pay privately for physical therapy. And I, in fact, have a couple of physical therapists that I refer people to. And I'm not sure about the charges of one of them, but the other is very experienced at working with patients under hospice and is extremely reasonable fee. So that's a possibility. But generally, what hospice will cover under Medicare is a consult or two for to understand body mechanics, to maybe instruct caregivers and family members on safe transferring, like from bed to chair and that sort of thing, but not ongoing physical therapy or occupational therapy. I just want to go back for a minute and mention, because I think I sort of skipped over this, that we really do try to be holistic, and it's our obligation to provide for not just the physical, but psychosocial or emotional needs, as well as spiritual needs. Spiritual care is very broadly defined. And, a lot of people, when they hear about there being a spiritual counselor available or a chaplain, are very quick to decline that service. And I just want to point out that whether or not one is religious per se, first of all, we find that a lot of times, and it only makes sense, that when approaching the end of life, questions come up, existential questions come up, some soul searching comes up. So whether or not it's of a religious nature, our spiritual counselors, and I'm sure this is true for the vast majority of hospices, are trained multi-denominationally and non-denominationally. So connecting in terms of what is spiritual for one person is really just about what brings meaning, what has brought meaning to your life, and connecting in that way. So that could be about gardening, or through yoga, or music. Which brings me to the fact that I happen to also be a board certified music therapist, and some hospices provide that service. And music is a very powerful tool in connecting to emotions, and sort of sometimes cutting through some defenses, and also in bringing people together in a way that doesn't require words or speaking, may not even require singing, may require just listening or playing, or maybe singing, or improvising something. So all of that is doable or facilitatable with a music therapist. And of course, social work, which, as I said, and I'm sorry if I'm being redundant, supports both the patient, the family, caregivers, anybody involved in the person's life with both the softer core areas like emotional needs, dealing with grief, sometimes an impending loss brings up other past losses. Sometimes it's about trying to get family members on the same page, who aren't totally in agreement with the care, just meeting together, trying to improve relations. And then it's also about the more concrete services. If, caregivers, uh, other agencies that need to be involved for any reason. And then also volunteers. And I work closely with the volunteer coordinator. And, it's a funny thing. Sometimes people will open up in a way in what seems like a benign relationship. Might share things with a volunteer who's there to maybe read uh, or help with some chores at the house. And so again, none of those are required disciplines, but they're all available under hospice care. Hospice started as a volunteer movement. So that is Medicare's nod to that fact is it is required that hospices provide at least a small percentage of their service through volunteers. So with that, I think I'm gonna pause and open things up to questions.
Hi, Laura. Thank you for your meaningful presentation. I know we all learned a lot. We did receive a few questions in the Q&A, but if you have any other questions, please feel free to enter them into the Q&A. I think we received one in the chat, so let me go back there. So someone is asking, why isn't palliative care immediately prescribed simultaneously / concurrently with a diagnosis of glioblastoma to address the social emotional needs of the patient?
That is a good question. I don't actually we provide palliative care. I don't work in palliative care, but I do think that like hospice, it often is not ordered palliative care soon enough. And it's a really good question because I think it makes utter sense to get on board with palliative care, certainly with a glioblastoma. That's a really major diagnosis that has, major consequences on the patient and the family. And I would imagine that it's possible to do it and to request it. Sometimes, we have to be our own best advocates. Can't imagine what reason there would be to not be able to have palliative care in place right at that juncture.
Thank you. And someone asked, can patients receive radiation or other treatments if it is to help relieve pain? I'm not sure if they were talking in terms of hospice care or palliative care, but
Right.
yeah.
So that's the thing. I know that sometimes radiation and even chemotherapy are used really to palliate symptoms, not for curative purposes. However, both are not considered compatible with hospice. But the good news is that yes, when under palliative care, one can continue to do radiation. Absolutely. So I think the idea would be that, when radiation ceases to have a real benefit, when there are really diminishing returns, or when even radiation just becomes harder to tolerate, that would be the time to say, okay, now I really don't want to do, not able to do, don't want to do any of these measures that are considered more aggressive, at which time hospice would be appropriate. But until then, hospice would not be possible.
Thank you. And we got another question that is asking, if a doctor's order is required for hospice, do oncologists delay discussing this and wait for patients or caregivers to bring it up?
Well, that depends on who your oncologist is, I think. You know, I think now the training is much better. I think some of the more old school doctors are really uncomfortable with it. This is their mission, is to fix and to cure, and it's very hard for them. Um, so again, sometimes it's worth asking, because there was a shocking article, I think it was called How Doctors Die, and it really underscored, well, it really made the point that there's really a kind of a double standard for many doctors, not for all, that what they recommend to their patients is very different than what they would do for themselves, that they're still recommending treatments long after the time that for themselves they would stop treatment and go on to hospice care. That was quite a number of years ago, and I want to say it was like a doctor affiliated with USC that wrote that, but I could be wrong. So certainly to ask the question, I want to be realistic here. Is this a time to consider hospice? I mean, if someone is having some side effects, but chemo or immunotherapy or radiation are really doing a pretty good job, or questionable enough that's worth pursuing another round or longer, then I mean, that too is the patient's decision. But when they cease to really be effective, and sometimes things continue to be prescribed to anybody anyway, and then the body gets kind of racked by all the treatment, and such exhaustion ensues, that part seems um you know like a shame. So hopefully one's doctor would recommend or bring up at least the option of hospice in a timely way, but that's always something that a patient can bring up, and sometimes your bringing it up will make them more comfortable to which is not the way it's supposed to go, but so there you go. Yeah.
Thank you. And then one other question. Someone said it was reported that President Carter was on hospice care for a prolonged period. It seems he was aware of the terminal nature of his cancer. In extended hospice care like this, would care be covered?
It would. I mean, it would. A little caveat. He's a president, but he so any person who's not celebrity in some way, again, if he were actually showing signs of decline, he would continue to be. And that's why I said we have had patients on, I don't know that it's been more than 2 years, but definitely has been 2 years, because the medical team of part of the hospice team could absolutely show that there continued to be decline, whether it's loss of weight, need for more medication, experiencing more pain, other symptoms, issues with sleep. So I'm just saying that one would assume that was the case with President Carter, but it could also be that they weren't going to kick him off because he was the president. I don't know. But he did die, so he probably was declining. I mean, it was real. And on that note, I just want to throw in one thing. I just want to recommend that if and when people are at the juncture where they are considering selecting a hospice, I want to just strongly recommend choosing a hospice that either has a good word of mouth referral, or your doctor referral, hopefully not because he's or she is the medical director of that hospice, but or to at least check reviews very carefully. In LA County, we have far too many hospices, more than are needed, and not all are, unfortunately, not all are ethical. I'll just leave it at that. So there actually need to be fewer. But anyway, so there, and for instance, there are hospices that will promise people, in order to get them to sign on, that they will have something, and this is one thing I didn't address, I'm sorry, something called continuous care, which is while on a hospice under what we call routine care, which is the most common level of hospice, where you're served in your home or assisted living or board and care, as I talked about. If somehow symptoms get so severe that they cannot be controlled, a hospice is required to provide something called continuous care, where a nurse comes in for several hour stretches and monitors the person, sits right at their bedside and provides whatever medication is needed, is in consultation with the doctor until the symptoms are controlled. There are some hospices that promise that to people. So basically they're promising that they will provide somebody at the bedside, when the truth is, according to the regulations, that is only to be used. It's very, very clear. It's only to be used when symptoms are not managed, not controlled. And thankfully that rarely happens, but when it does happen, we're on it. So there are all kinds of funny tactics that some of the less bona fide hospices will unfortunately use. Onward.
Thank you. And we received another question. Someone is asking, how does one get, it's two questions, it's a two-part question, but how does one get siblings and or spouses to honor a patient's final wishes in regards to end of life? And second part is, legally, can a family member remove a patient off hospice?
So the first question, I'll do the second question first. A family member cannot remove a person off of hospice unless they are the power of attorney and that person, the patient themselves, does not have capacity to make decisions, either because of dementia or some really altered state of cognition. But if they do have capacity, nobody but the patient could decide to go on or off of hospice. And I'm sorry, I forgot the first one.
Yeah, no worries. How does one get siblings and or a spouse to honor a patient's final wishes in regards to end of life?
Aha. I don't know if you're talking about choosing to go on hospice or choosing medical aid in dying, but the best way is honest discussion, and if necessary, bringing in either a therapist. If the person's already on hospice, hopefully the social worker can help with that. Sometimes even an end-of-life doula can help with that. And sometimes you cannot change people's minds. These are very often deeply rooted, issues, and that are foundational to the family dynamics. There are all kinds of things that happen, but of course, that's the optimal, is that everybody would want what the patient wants. And I'm sorry to use the word patient, very medical model, but those are our terms of reference. It's a medical setting, hospice, even though it's much more.
Thank you. And we have one final question. Someone asked if you could please explain medical aid in dying.
Oh boy. Well, are we stopping hard stop at 1 o'clock?
No, we can go a few minutes over.
Okay.
Yeah.
So medical aid in dying, or in California, what's referred to as the End of Life Option Act, is it's assistance in death. It's not euthanasia. So to it entails drinking a cocktail of, I believe it's 5 different medications. It is legal in California. Um, it it involves drinking a cocktail. It's like 4 ounces, I believe, and it a person goes to sleep, and then usually within an hour or up to 6 hours at the most, they pass, they die. Um, to elect to use medical aid in dying, the main criterion is the same as for hospice, and that is a diagnosis, a terminal diagnosis with a likelihood of 6 months or less to live. It's a little more firm of a criterion because this is such a very irrevocable decision. So any doctor that's going to write a prescription for medical aid in dying is going to want to see medical records and, speak extensively with the patient and be sure that this is that their diagnosis is what it is, and that this is what they really want, not just like today, but not tomorrow, and understand the reasons and make sure that they really have the capacity to make that decision, and that there aren't psychiatric issues that might be coloring the decision. Um, so and it's very much actually recommended by most people who do prescribe the medicines for medical aid in dying that someone be under hospice care, because you get all that support while going through this, and you get a little bit of guidance for I have some sort of strong feelings about the importance of some kind of ritual, or at least discussion with family or with whoever is important in your life before going through with the act of taking medication, for not only for the patient's sake, but for the people in their life, because um, it's a more abrupt ending. But it really honors the dignity of the individual and the right to self-determination. Um, so, super, super important in that sense. And we've worked with many, many patients who have used medical aid in dying. So the basics of the process are that, by the way, most doctors will not prescribe medical aid in dying in general. Those who do, usually the vast majority of cases only do it for their own patients. They won't do it for, so if we have somebody that came onto hospice care, and the person has decided or decides along the way that they really want to pursue this, we happen to have a doctor. There aren't too many. We have a really excellent doctor and team that we refer to, and he will prescribe. Sometimes an oncologist will do it. We've had patients that have very close relationships with their oncologist, and they think, oh, he's going to do this for me. But it turns out that that person hasn't had the experience. They don't know exactly what the prescription is. They don't know which papers to fill out, and they don't have the bandwidth to be able to go through it. Some are educated. I know that UCLA doctors have relatively more experience with medical aid in dying. So it takes one doctor who meets with you 2 times, and it can actually be just like this on Zoom. It doesn't have to be in person. Within 48 hours, there has to be at least 48 hours in between the 2 meetings. Then there's a second confirming or consulting, I forget what it's called, doctor. And so it can all happen within a very short amount of time, certainly within a week from the start of the first meeting. And then there's a second meeting with the one doctor, and then there has to be someone who witnesses. But again, I can't stress enough the importance of planning for it, not just in terms of the appointments and getting the medication, but in terms of what do you want that end to look like. I mean, on the one hand, it's a great gift to be able to sort of orchestrate that, and on the other hand, it can be jarring for those who are left behind. So having some really proper closure is important. It's optimal anyway. Yeah.
Thank you. Thank you so much. We have reached the end of our time, but I do want to thank you once again, Laura. We really enjoyed having
My
you here
pleasure.
today.
My
And I
pleasure.
know we all learned a lot, and I want to thank our attendees as well for your engagement and your meaningful
Yes.
questions. Yeah.
Thanks for me too, for being here.
Yeah. And then we do have one last closing slide. Thank you, Sigal. Yeah, so this slide has our contact information. So if you would like to learn more about Cancer Support Community Los Angeles, please visit our website at cancersupportla.org. And if you have any questions, please feel free to email us at info@cancersupportla.org. Laura has also graciously agreed to share her contact information. So if you would like to contact her and do some follow-up questions, please feel free to email us and we'll give you her contact information. And one last thing is we have an online workshop series that began on April 17th and it'll go until Thursday, May 22nd. It is held online every Thursday from 6:30 to 7:45. If you would like to register, please feel free to scan the QR code. And if you have any questions or trouble registering, please feel free to reach out to us. I want to thank Laura one last time, and we hope to see you all at our future webinars.